are in listen-only mode.
Well, hello and welcome to the ABCs of MIPS, our monthly broadcast looking at how merit-based incentive payments will impact your bottom line. I'm Carol Flagg of High Tax Answers. Thanks for joining us today. On this one-hour program, we address your questions covering the full spectrum of the payment program alphabet, including MU, PQRS, VBM, and more. On today's program, we will discuss understanding value-based modifier, how to read your 2014 QRUR. Our expert, of course, is Tom Lee, founder and CEO of SA Ignite. Tom is a well-known and respected technology innovator and leader in the health IT space and brings his views and compassion to pretty much everything he does, including this show. If you have a question during the broadcast, please email him directly at tom@saignite.com. Tom, welcome back to another ABCs of MIPs.
Great to be back.
Yeah, fun times. Listen, I'm going to go ahead and put myself on mute, and I will see you back on the Q&A.
Sounds good. All right, I'm going to grab control of the presentation here. And so, by way of recap from our last couple of webinars, continuing on our real focus on the value-based modifier, and here's just a reminder of how VBM really fits into the overall MIPS program that will be rolling out over the next couple of years. So MIPS, many of you have seen this, and perhaps some of you have not, but essentially it's going to have a really large impact ultimately on Part B payment. And there will be winners and losers from a financial perspective. And today, we're really focusing in on the VBM portion of this. We can see MIPS, it's basically 60% of MIPS will be what is known today as the value-based modifier program. And last week was an important week in the cycle of VBM in that CMS published the 2014 VBM report card, otherwise known as the Quality Resource Use Report, or QRUR. And so it's really very timely that today we'll be able to talk about that in greater depth. So today we're going to cover just what are some of the basics around what a QRUR report really is. Then we're actually going to take a tour of a de-identified 2014 QRUR that is an example of what many of you all have received last week. And we're going to then talk about some actions that you can really take based on the information in the QRUR, some things to think about, some things to examine, and potentially some things to immediately take some action on. And we'll also take a brief look at some other resources. Our company has recently published a whole new set of value-based modifier FAQs on our website that I'll show you at the end. And then we'll get right into our open Q&A as usual. So let's start with the basics. First of all is who gets a QRUR for the 2014 year that was just released last week. So typically 8-9 months after the performance year is when CMS will allow you to get yours. For the 2014 performance year, it was all tax IDs, all groups with tax IDs in which there were 10 or more PQRS eligible professionals and at least one physician. The folks who are excluded from really VBM for the 2014 year, but I actually still believe that you will get your QRUR, but are still exempt from the program, are any Medicare Shared Savings Program ACOs, Pioneer ACOs, and CPC Initiative organizations. Now, for the 2015 performance year, which is this year, in which you would get your QRUR next fall, the VBM actually does apply now for the very first time to these organizations for this performance year. And as a result of that, come fall of next year, all TINs nationally that bill Part B will receive a QRUR like the one that we're about to look at. Okay, so the QRUR is simply understood as the report card from CMS for how you did last year. And as we'll see in a moment, it contains both quality and cost scores, which are the two primary dimensions along which your organization is rated against peers nationally. And those scores directly drive your payment adjustments to Part B for next year. So there's always a 2-year lag between the performance year and the payment adjustment year in VBM. And for the 2014 performance year, the adjustments to be applied next year can range from a 2% penalty on the low side to neutral to 2 times what's called an adjustment factor percentage for those who are in the top probably 10% nationally in performance. So just to give you an example of what that bonus could end up being, the bonuses that are being paid this year for the performance year of 2013 are around 9.8%. Basically, that's 4.9 times that factor. So pretty substantial upside that can be gained from this program alone. And this all gets magnified once MIPS rolls out, and VBM is making up 60% of that. Now, for TINs that are within a certain size range, for the 2014 performance years between 10 to 99 eligible riders, those organizations are not subject to the negative penalty. They can only potentially get a bonus. Now, for this performance year, for 2015, in contrast, that free pass ends where all TINs that have 10 or more providers are subject to potentially getting a downward adjustment for low performance. Okay. Now, one last point of clarification, this is a common question, is to really understand that all of these VBM payment adjustments are separate and apart from the PQRS program's 2% penalty for not meeting the minimum reporting requirements. Okay, so for example, if there is a TIN that failed to register for GPRO and failed to report via a GPRO mechanism, would get a penalty of -2% from VBM, but also another -2% from PQRS. Okay. So here's some nuts and bolts. How do you download yours if you haven't already? Here's a convenient URL. We'll be distributing this presentation as usual afterwards, but I can show it here for a moment if you'd like to write down some of these digits at the end. Instructions from CMS step-by-step on how to do this. One suggestion is to also download all of the supplemental exhibits, which, as we'll see in a moment, contain a lot of rich information that may not necessarily be directly related to your score or your payment adjustment, but gives you sort of the whys behind the score, which is very, very informative. And in general, CMS has one comprehensive page that really describes everything around QRUR with sample reports and data definitions and things like that, and we'll also take a look at some of those. Okay, so last piece here, before we get into really looking at a QRUR, is just a quick reminder primer on the quality and cost scores and how they're calculated. So CMS maintains a VBM calculation algorithm, and the inputs to that are, first of all, your submitted PQRS quality measures through any one of the mechanisms that are available. From the claims data, CMS is able to calculate both a set of quality and cost measures. And then also there are annual VBM benchmarks that CMS uses to really calculate through this algorithm both your quality score as well as your cost score. And each of those scores independently are put on this scale. So for example, if we're talking about the quality score, if you see a quality score on your QRUR that is above 1, then that alone will net you this bonus. If on the other hand it's below -1, then you will see that it nets this penalty. And same on the cost side. So really added together, that's how you get your plus minus 2% with the adjustment factor on top. Okay, and again, the organizations in the size range are exempt from this bottom tier only for 2014 performance. Okay. All right, so Carol's going to hand over to my desktop, and let's see if we make this work. It looks like we're going to be able to do this. All right, so you all should be looking at my desktop here in sunny Chicago. Enjoy it while it lasts. So what we've assembled is a de-identified QRUR, really based on what was released last week by CMS. And I'm going to basically give you all a grand tour of some of the key components of this and try to highlight some areas to really zoom in on when you're really looking through yours. This page 2 here is really the summary side, where it shows, for example, in this case, this is the quality score on that scale of -1 to 1, and here's the cost score. And actually, I neglected to mention that the cost score is actually inverted, so that the negative scores are actually better, not worse. And so in this particular case, you can see that this tax ID is really in this position on the quality and cost axis, where every single one of these dots is another tin nationally. And in this case, it's an organization that has at least 10 providers. And so all these dots are all the tins that have at least 10 providers that are subject to VBM from across country, and for which there has been enough data submitted to calculate the quality side and the cost side. You'll see further below, and this is really where the impact is really summarized. So for example, in this case, there's neutral adjustment because this organization is average on both axes, quality and cost, and so you have neutral adjustment here. If, on the other hand, a penalty adjustment were to be assessed, you would see a -2% here, or on the quality side, you'd see the +2% times the AF factor. For those of you who are fortunate enough to get a bonus, the AF factor will be published later, typically later in the same year, especially later this year, in a separate document on the CMS website. You can really see what that ends up on the upside. And then here you'll also see some other notes. And one really important one is for any of you all that have reported your providers in 2014 on an individual provider basis, rather than doing GPRO, that there is a requirement that at least 50% of your providers, if you decided not to do GPRO, have to have reported individually and met the minimum PQRS individual reporting requirements in order for the TIN to avoid an automatic -2% adjustment. Early signs is that there are some issues potentially with some of the QRURs that have been generated by CMS, and we'll come back to that later as that unfolds, and some things that you can do if you're in this situation. You're getting an unexpected -2% adjustments, what you can do to find out the root cause, and potentially even apply to CMS to have a review of your situation. Okay, so we'll come back to that. Now moving on, and there's a lot of information here. I'll spare you all the details here. You all can get really a sample of this sample QRUR right from CMS's website. But I just want to go to some highlighted areas here. So the first exhibit can be quite interesting because this can tell you how CMS determined the number of eligible providers you had, whether they used your registrations in PCOS or whether they looked at the number of claims that were submitted by these professionals, and they actually used the lower of these two numbers. But you can also see the breakout, for instance, of how many of those EPs were physicians versus non-physicians. Now this becomes important in future years because for this 2014 performance year and where the adjustments for next year, the payment adjustment will only be applied to these physicians' Part B payments. And the non-physicians are actually not going to have their payments adjusted. So you can see there'd be potentially a 28% 6% difference roughly in the number of providers that would get adjusted. Now moving forward, it's being proposed for 2016, the 2016 performance year, which would be the 2018 adjustment year, that non-physicians will also have their payments adjusted. Okay, so it's just something to track as the program unfolds, and you're trying to, from a finance standpoint, project how much of money you have at risk or could get. It depends largely on this table. Okay. Now we're going to skip over to Exhibit 3 here. This is a pretty interesting one. So one of the real benefits of seeing a QRUR is that you can understand how your patients are experiencing care in organizations outside of your own. Simply because CMS gets a lot of claims data really from across TINs. And so, for example, this one's interesting, is the primary care services that have been provided to your patients that have been attributed to your TIN. And there are really, the way the rule generally works is that if your TIN has provided most of the primary care services, then that patient will be attributed to you for a number of the quality and cost measures that will be shown below. But what you also see in here is, for example, on average, how many services per patient per year are provided by TINs outside of your TIN. So if you're looking to really understand what % of your patient's care from a primary care perspective is being delivered outside of your TIN, it's the ratio between these two numbers. Pretty interesting stuff. Okay, so let's get right into the quality side of the equation. And one really interesting note that's really late breaking in the QRUR is for any of you all that in the 2014 year submitted data using the QCDR method or the EHR reporting option, or DSV, that CMS really looked at all the data nationally and determined that there was some real issues with the overall accuracy of those forms of data submission. And so as a result, you will not see your QCDR nor your EHR measure values reflected back to you in the QRUR. And really what the decision is here, where you can read this on your own, is that for such organizations that reported through QCDR or EHR, the worst they can do is average on the quality dimension. And however, if that data would have gotten them in the high tier in the bonus, then they will get the bonus. Okay, so it's kind of another free pass for these reporting methods. Anticipation going forward is that this will not be the case for every year going forward, because now there is a lot more activity regarding these two reporting methods, and CMS is anticipated to work out the situation. Okay. So anyway, here's really the more detailed scorecard for the quality side. This is the key number, 0.54, that you all saw up in the scatter plot up above. Okay, that's really this number here. But what this table break does is it breaks down the components of that score into different quality domains. So you all, may remember that you may have selected 9 measures across the 3 domains, or if you were a GPro web interface submitter, you would have had 17 to 20 measures scattered across multiple domains. And it basically, the way VBM works is it gives you a score for each individual domain. And it has a way of essentially comparing your performance against that of other TINs nationally to derive this final score, 0.54, which is really gives you your adjustment, as we saw above. Okay, so this is a really good thing to kind of verify. And to verify things even more is, here are the actual numbers that you submitted for 2014, all rolled up to the TIN level. So for example, if you reported providers as a GPro, you should see your GPro values here. If you reported providers on an individual basis, so let's say if you had 100 providers in your whole TIN and you reported 80 of them individually, and thereby you would have exceeded the 50% threshold to meet the minimum reporting requirement for a value-based modifier, then what you should see here is a sum of all of your measure values across those 80 providers you submitted. Okay, so that's really what physically these numbers are. And it doesn't matter what reporting method you used. CMS has a way of really reflecting it all in these same tables that are split by domain. For example, this is the effective clinical care domain. And what's interesting here is you can see what was the measure benchmark, really an idea of what was the standard deviation or that national spread in that score, in that measure, performance rate nationally, and then the standardized score, which basically tells you for that measure how many standard deviations were you above or below this national benchmark. And these measures are all included using a variety of different rules, or not included, in your final quality score. Okay, so this is an interesting place to look for outliers. And one characteristic of an outlier where there could be opportunity is where you have a low number of eligible cases and you have a score out here that you may not like. Okay, and what that might mean is that if you have a lower number of eligible cases, you may have more of an opportunity to make a greater impact faster on that measure, either even in the remaining part of this year. For example, if you're going to use the same reporting method this year as you did last year, or if you look towards 2016 to get a head start on performance improvement for 2016, given that the VBM is expanding to more providers and having a greater financial impact, you can use it for that too, to really look in and drill in. Okay. All right, so here's an interesting one, is in particular for organizations in 2014 that declared GPRO. When you registered GPRO in 2014, you had the option to include or not include your patient satisfaction CAP survey results into your VBM score. So in this example, this organization decided when they registered for GPRO to not include the score, these scores for CAPs, into their quality score. Okay, you can see it actually fits within the care and coordination quality domain. It's treated like any other measure that you would have otherwise submitted through PQRS. And if you see yeses here, that means that your organization registered and opted in to include the VBM score, and you would then see these scores really be part of driving what your overall quality score is. Okay. Another good thing to maybe review with your CAPS vendor is whether or not these numbers agree and it makes sense to them of what, in terms of comparing us what they submitted, or what they thought they submitted to CMS, to make sure that there were not any errors in that process. Okay. All right, so let's get into really setting up for the cost side of the equation. And one really interesting piece of information as we start to get into the cost side is that really what's happening with hospital admissions. And what's interesting about the VBM cost component is that although VBM is only adjusting your Part B payments, in other words, your ambulatory outpatient revenue stream, the program actually measures your provider's performance based on the fully loaded Medicare Part A and Part B costs of each patient. And so as a result of that, VBM is able to provide you in this QRUR with a lot of information about inpatient services. And here's an example, as you can actually see here, and this is all directly from the sample report, so that's why there's not actually non-zero, there are no non-zero numbers here, but you get the idea is that it can tell you, for example, or what are all of the hospitals that admitted the beneficiaries, patients that were assigned to your TIN based on your TIN providing the most primary care services. Well, where did those patients go when they were admitted to hospitals? Are there any rival hospitals? So on and so forth, and you can actually look at the number of stays for the 2014 and what percentage of all the stays did any given hospital make up. Okay, so and we'll come back to, there's more information in the supplemental exhibits that is of the same ilk that can be quite illuminating. So let's switch over to the cost side. So really here is the cost score, really in tandem with that quality score above that you'd see on the scatter plot. And there are a variety of different cost measures. For example, what is the per capita fully loaded Part A plus Part B cost for every one of your attributed patients? And it also, there's another measure where CMS breaks out patients into particular chronic conditions and asks within, let's say, the diabetes chronic condition, what is the per capita cost per diabetic patient, okay? And again, really rating that against national benchmarks. And you can see an example of that down here. This is the table for the fully loaded cost, regardless of specific condition, across all your beneficiaries. You can see what the national benchmark is for annual per capita cost. See the variation, see your standardized score. That tells you how many standard deviations you are below. And here, this is really where having a negative score is good, because you're below the cost metric. All right. Here's another interesting one. This is really looking at both for all your patients as well as for the specific for chronic conditions. What are your average per capita costs annually for different types of services? And what's interesting to look at here is the outliers. So for example, on the E&M side, this appears to be above the cost metric. If you look at all of these variations, it seems to be high, and this one seems to be low, and so on and so forth. Okay. You can see here, you can see some really sizable potential variations from benchmarks that are noteworthy. Okay, so almost rounded out with the main summary PDF. This is the summary QRUR. That is really where most of the main information is. Okay. So let's switch gears now, and now let's look at some of the supplemental exhibits that I mentioned before that I also recommend that you also download. The first supplemental exhibit is very useful, is because this is basically the actual list of eligible providers that CMS has determined to be eligible for the 2014 year. And it breaks it out by whether the provider is a physician, non-physician, what was the specialty designation that led CMS to understand what type of provider they are for eligibility purposes. And it even lays out whether CMS found the provider to be eligible based on PCOS, billings, or both. And also even when was the last claim that was filed on behalf of that provider, which may indicate to you if certain providers have left the organization in 2014. And that could have implications for how you may want to look at this list and really think about the size thresholds that we just discussed before. For example, the 10 to 99 tier, the 100 and above tier, just to see if CMS is reflecting back to you roughly the same number of eligible providers as you originally thought back in 2014. And in particular, how many providers you thought you had in 2014 when you registered for GPRO, if you registered for GPRO, because GPRO has very strict size limitations, size constraints. This is a great thing to kind of give to your credentialing department or your finance department and say, how much are we similar or different to this for 2015 before the 2015 year ends? Because if you find large differences, that could be something you want to focus on before you submit your data for 2015. Okay. Here's another interesting one that goes down to the patient level, and it's really looking at patient by patient, all identified by the HIC, the claim number. Very detailed information. How many primary care services were provided by your TIN to that one patient? The cost, the EP involved for both primary care and non-primary care services. Very interesting patient level information. You can think about ranking these or ordering these by who are the highest users of primary care, who are the highest users of non-primary care services, and so on and so forth. Here's another beneficiary one that really gets at the cost per patient and for different categories of services. This exhibit actually tells you which patients were really factored in to your CMS's calculation of, for example, the number of hospital admissions that we saw in the table previously in the main document. So for those of you who are really interested in cost accounting and really looking at trying to figure out where costs can be attributed to, this is the CMS view on that question. Okay, it's basically per capita costs by different categories of services for all the beneficiaries, and you can really see certain patterns, for example, spending patterns, among different categories of providers, spending patterns relative to what was billed through your TIN for your beneficiaries versus how much money was billed by other TINs. Give you a sense of your patient's out-of-network experience and spend. This is very similar, except it focuses on beneficiaries that have diabetes with one of the chronic conditions. All right, the last two here. This is for organizations that submitted their PQRS data on an individual provider basis for 2014. And this basically tells you all of the measure values for every single provider that you submit individually. So this could be fairly long if you have a large organization. The one notable thing, extending off what I said before, is that if you submitted measures via QCDR, EHR Direct, do not be alarmed if you don't see your data here, all right? Because CMS is purposely not included here. But there is an issue that seems to be proliferating right now regarding EHR Direct in particular, that could be an error that would justify having a review with CMS, or CMS may be actually addressing this fairly soon. I'll come back to that. Okay. All right, and then the last exhibit here of note, and there's many other exhibits here you can also look at. In the interest of time, I won't cover all of them. But this really is just a summary of, for really GPROs, what are your incentives, that you may have earned from that effort in 2014. Okay. So that's the grand tour, and Carol's going to go ahead and show the slide deck again, and we will round this out and get right into Q&A. All right, thanks, Carol.
All right, I think I'm back.
Yes, you are.
All right, I think this is you, though. I'm going to give you got actions to take, so let me give you, you've got control of the PowerPoint right now. Go ahead.
Great, thank you. All right, excellent. Okay, so let's really talk about some things that you can do based on some of this information. And actually, Carol, I think I have not taken over the keyboard quite yet. No, there we go. Okay. So the first thing to do is to look at that QRUR and say, is there anything really sticking out that could be a potential error? And CMS has actually laid out on the QRUR website that they host that there is a review process. They call it informal review process. And here's really how you engage in that. And Carol, I think I might need you to click through this because I'm still not having control on the mouse. Okay, so there is a deadline, which is by November 6th of this year, is that if you do want to request a review, there is a process, an online process by which you need to do that by November 6th. Next bullet. And that may involve really gathering some of your supporting documents to really help to show CMS why you think there may have been an error. And of course, this is for folks who unexpectedly may have received a payment penalty. And the one issue that has come up in the market now is that there are organizations that submitted using EHR Direct in 2014, both GPRO as well as individual provider, where they are now getting QRUR reports back that are saying that that CMS did not receive their data, or where there was some other glitch potentially that makes it such that they are, from CMS's perspective, they are not exceeding the 50% provider threshold, or not even exceeding the not even meeting the raw GPRO submission requirement, and thereby getting docked 2%. Okay, so this is something that's unfolding now. Feel free to reach out to those you know, to me if you like, if you're seeing that, and we try to direct you in the right direction. But this is really the way in which you would formally request a review on that from CMS. But look for updates from CMS on this, because it's starting to really spread, and I think that there may be some information coming from them fairly soon on that. Next. This, as I mentioned before, is that exhibit number 1, supplemental exhibit number 1 with your PQRS eligibility list, is something that, particularly for those of you who are filing for 2015 individual providers. So for this year, you're filing providers individually. That's a great resource for you to make sure that you understand who was deemed eligible, who was deemed a physician versus a non-physician, so you can make sure that you have the most accurate possible 2015 PQRS eligibility list as you possibly can. Next. And really identify some of the low-hanging fruit, for score improvements. Next. We talked about focusing on outliers. Looking for example, low scores that also have low denominators could be some places you can make a big difference fairly quickly. And finally, look at the potential of selecting different PQRS measures for 2015 than you did for 2014, based on what the 2014 submitted measures deliver to you from a BBM perspective. So for this, I actually refer you all to our previous webinar, August 20th. You can find links to it on our website as well as the High Tech Answers website, where basically we go through some scenarios where selecting measures differently can really have a very large impact on your VBM score. Next. And really quickly, some other resources I mentioned. Just released last week our VBM FAQs on our website. Here are a couple ways to get there. Next. Open invitation to join our MIPS group on LinkedIn. We have approaching 100 members now. I'd love to see you there. And finally, also on our website, many of you have seen this before, continues to get a lot of traffic, is our FAQs about the MIPS program in general, including a free financial calculator that you can download and use to really run some MIPS impact scenarios for your organization. And then all of these recordings and the presentations are also available through our website. This one's also being recorded too for those of you who have colleagues who were not able to make it today. All right, Carol, I think I'm ready to hand it back to you for some Q&A.
Yeah, and just to remind people on the broadcast today that also all of the ABCs of MIPS webinars are on our High Tech Answers YouTube channel. So if you go to High Tech Answers and hit the little YouTube at the top of the page, or go to YouTube and search High Tech Answers channel, you'll be able to see them as well. Several questions related to copy of the presentation and recording. As always, I'll get that sent out to everybody probably by Monday. So we should probably just move right into the Q&A. So we had quite a few questions from today's registrants, but we also have quite a few from the broadcast today, and I thought I'd start with those since they really are directly related to the conversation around QRUR. Obviously, in quite a few of the slides, you talked about what happens with groups that are greater than 10, that they might be exempt from certain penalties. One of our listeners wanted to know, so what happens to groups less than 10?
Great question. So it depends on the performance year that we're talking about. So for example, for the 2014 performance year, where we've just looked at one of the sample QRURs, that will affect payment adjustment for next year. That for organizations that had less than 10 EPs in 2014, there is no QRUR that you should have been able to download. Now, if anyone was able to download one that is of that size, I'd love to know about that. But that's what CMS originally said, is that those QRURs are only for the larger organizations, 10 or more. But regardless of whether you get one or not, for last year, or I'm sorry, for 2014, the any kind of negative payment adjustment would only apply based on your quality performance, would only apply for organizations that were 100 or greater. For those that were 10 to 99 in 2014, there's the possibility for a bonus, but they're not subject to that payment adjustment based on performance. Now, everyone in the 10 or greater category is subject to the automatic negative adjustment for not reporting their PQRS at all, or the PQRS measures at all. And that BBM, automatic negative adjustment, is additive to the standalone PQRS minus 2% adjustment that I described before.
It is also talk about this algorithm based on what my peers are doing. Somebody wants to know, who are my peers? Is it based on practice size and specialty, or are there other factors involved? Mm-hmm. Great question.
Yeah, that is a great question. Again, that has changed from year to year. For the 2014 performance year, for organizations that had 10 or more providers, is really all the TINs nationally that had 10 or more providers that were subject to PQRS. That would be that, and that's irrespective of what was stated by CMS. That was irrespective of specialty, of regional considerations. It was all in one single cohort. Now, however, in previous years, for example, the 2013 QRURs, we were able to see that there are actually multiple cohorts around the country. So in terms of what they may do for the 2015 year currently, it really remains to be seen if they might fine-tune the cohort groups, the peer groups, when it comes to comparing your organization to other organizations.
And just somebody looking for clarification related to the previous question, did I understand correctly that only organizations with 10 plus providers will receive a QRUR report for 2014? And if so, what about 2015, 2016, and so on?
Yeah, so for 2015 performance year that you would receive fall of next year, it's all TINs in the country. Even solo docs are going to get a QRUR.
Everybody, yeah.
Yeah, everybody will get one. And again, I'm actually right now looking at the 2014 just to make sure I answered that question previously about the 2014. Will you be able to get it if you're less than 10 docs? I'm 90% sure that you're not going to see it up there if you have less than 10 docs. But if I find otherwise, I'll try to tell you all right now. But otherwise, let's keep on going with the questions.
Keep on trying. And we could obviously this is a monthly program, so we can address that in the future as well. How do you another really good question? How do you see specialists faring with this system? There are already issues with PQRS being weighted to PCP type measures. I guess really just your opinion.
Yeah, Carol, could you actually ask that question again? I apologize because I was distracted for a moment. Sorry about that.
Yeah, no worries. How do you see specialists faring with this system? There are already issues with PQRS being weighted to PCP type measures.
Yeah, it's a common issue. It's part of it is just due to the limitations of the measures that you have available to you based on the PQRS method that you pick. So, for example, if you are using the G-Pro web interface method, you have to report on all 17 or all 20 of those measures, depending on what year we're talking about. If, on the other hand, you do a registry method or you use the EHR direct method, then you have a much larger range of measures to choose from. It can be more specialty friendly, but it's hardly perfect. The one fact to really understand with PQRS with respect to specialists is that if you look at the way in which measures are defined, very often the specialists can tail off of the efforts of the primary care providers if they're all under the same TIN, for example. And that's because many of the measures are based on patients and patient visits in terms of denominator and numerator definition. as opposed to which provider actually did the work.
Mm-hmm.
Okay, and you could have two providers that have that patient, have seen that patient, but only one provider really has a relevant numerator and denominator for that measure, and then the specialist is going to get automatic credit. On the other hand, if the primary provider does not do well, then the specialist will also appear to not do well. So there's a certain kind of group effect there that I'm describing, and part of the real trick here is to understand how some of those things can impact specialists in a way that may have nothing to do with their workflow, and balance that against other measures you might pick where the measures do have something to do with that specialist workflow. And then the other complicating thing on all this, to not try to confuse the issue, but it is a real concern, is that all these measures are publicly reported to consumers,
Right.
through Physician Compare. So all the 2014 data will be out there in 2016 through Physician Compare. So then you have to think about, if I have consumers starting to look at this information, and third parties will have access to this information as well, the health grades, the vitals.com, what would those measures look like to a consumer who's looking for a cardiologist, for example? Will it make sense that the cardiologist somehow is doing very well on the flu immunization measure, for example? Is that something that the marketing department is comfortable with consumers seeing? Carol, if I may, I want to actually correct something I said previously in response to the first question. I'm actually looking at the CMS webpage now, and I actually misspoke. Is that for those of you who are looking to get your 2014 QRUR, it turns out that every group practice and every solo practitioner nationwide can get their 2014 QRUR now. I personally have not seen one yet, but I'm sure it will come soon. I just wanted to correct that.
Okay, great.
But even if you get your QRUR and you're less than 10 docs, just know that it's CMS's way of giving you a preview of what your performance would have been if you would have been subject to a payment adjustment, which you're not, for the 2014 performance year based on your performance.
Oh, that's good.
Okay, so you can
right, if you're on 10 providers, right?
Yes, exactly.
Great. Do you know? Are you aware if residents are included in QRUR in the reporting?
Yeah, another excellent question. So the QRUR is really based on who are PQRS eligible providers, and the reason why is because the value-based modifier eligibility criteria really is tied to PQRS eligibility. So, for example, if you decide not to report PQRS at all, then your provider will not only be docked the 2% from the PQRS program for not reporting, but will also be docked another 2% from the value-based modifiers, all tied to PQRS eligibility. So with respect to the residents, or really any type of provider, there's two criteria you want to look at. One is, has that provider been paid any Part B in the year in question? Okay, and really it's looking at the 2014 payment year. 2014 year, whether or not the provider was paid Part B in 2014. That's data point number one. Data point number two is CMS annually publishes a PQRS eligibility list, which you can actually navigate to from some of the links that I provided previously. And if your provider is of a provider type that's on that list and bills Part B and has been paid Part B, then that provider is PQRS eligible. So one rule of thumb, for example, for many of you that have looked at, that are participating in meaningful use, like Medicare meaningful use, for example, typically we'll see that the number of PQRS eligible providers you'll have will be something like 30 to 50% greater than the number of meaningful use Medicare eligible providers you have.
I've got a PQRS question, but before I ask it, real quick question: does an ESCO qualify as a VBM, or will it be excluded like an ACO?
An ESCA, ESCA?
She typed it in ESCO. The acronym is ESCO. So I pronounced it ESCO.
I am not familiar with ESCO. I apologize. That might be an offline question we'll have to answer.
I'll have to figure that out.
I'm not familiar with ESCO.
Right.
Okay.
Yeah, okay. Does the supplement exhibits that come with the QRUR report, the ones that you were, I think, showing your Excel spreadsheet, does it come with it, or does it have to be requested separately, all those supplemental exhibits?
So it's certainly through the same web page that providers go to download their main QRUR. Honestly, it's the ones I've seen have been downloaded by our clients. So I personally have not been in the download area of the website, but we have had pretty uniform success in organizations being able to get that to us. And certainly if you have trouble finding it, CMS does have a support line that you'll see on their QRUR website, where I have a link in the presentation. You can ask them for help on that.
Okay. On the cost score, is one of the things we looked at. Is it looking at the dollars on the claims submitted, or the adjudicated claim amount for a particular category?
That is a great question. There is, so if you, I don't have the answer on the tip of my tongue right now. I have a strong suspicion it is the payment, the fully adjudicated one, simply because the way in which the algorithm is described is that CMS allows for, I believe it's 3 or 4 months after the end of 2014, for all the claims to be adjudicated before they start the calculation. Okay, so based on that, I'm quite sure that it is the adjudicated actual paid amount out to the provider as opposed to what was initially billed by the provider but was not yet adjudicated yet. So it should be the post-adjudicated amount if I'm not mistaken. But you can certainly find that detail actually on that CMS website, the QRUR website that I mentioned before. It has it all in great detail.
Yeah, these are obviously some great questions to add to your growing FAQs.
Yeah, absolutely. Yeah, keeping them on the list.
as they come into into their own.
Absolutely.
On the hospital admit data, if a patient is admitted to one hospital, then transfers to another hospital, a larger hospital, does that count as one hospital admit for that beneficiary or 2 admits?
That is yet another question that has stumped me. That's a great question. From what I can gather, and I'm actually looking right back at that part of this de-identified QRUR. First is that there is definitely description, more detailed description that answers that question in the QRUR documentation on the QRUR website. What I'm seeing here is that the hospitals that are listed each comprise at least 5% of all of the inpatient hospital stays for those beneficiaries. So there may be other hospitals that don't reach the 5% threshold that are not listed in Exhibit 7 of the QRUR. But that doesn't really answer the question. But I think it's a kind of a noteworthy fact that you will not see every single hospital on there, but only those hospitals that have at least 5%. But for the actual specific question, I would consult the more detailed CMS documentation around Exhibit number 7 to find out the answer to that question, whether the second referral would count separately or not. I suspect it would, because it's actually number of stays, which seems to be independent of how many times, how long the referral chain is. It seems to all be tied to the number of stays.
Okay. You actually get this, I think we get this question every time, which is, has CMS released info on how they are weighing the measures with regard to calculating the quality score?
Awesome question. I love this question. First off, I refer you all to the webinar number 3.
Number 3.
This one in August 20th. That gives you the background. Yes. So CMS, interestingly, has really kind of equal weighting. So, for example, if I have 10 measures in one quality domain, then when CMS goes to calculate and start to roll up those values to the final score, it will equally weight those 10 measures within that quality domain to calculate a quality domain score, and that will be equally weighted with respect to, even if one measure has a denominator of 1,000 and the other measure has a denominator of 100, they'll be weighted, their standardized scores, which is the amount of standard deviation they vary from the mean, will be equally weighted when it comes to calculating the average quality domain. So from this, you can kind of start to understand it, and this is why I refer everyone back to webinar 3 as to why it is that a very small change in one measure, for example, that doesn't even seem to have a lot of patients, can actually have an outsized, disproportionate impact to your score. Okay, it's because of the way in which these things are really not weighted. All right. Now, at the global scale, at the group scale, when you add up all the measure values, let's say across all your providers, well, then you are effectively averaging the individual measure rates because they're adding up all the numerator and denominator separately, or you're doing it on your own if you're a G-Pro. So in that area, which is separate but related, there is weighting that's going on that's denominator weighted. So I know that's a lot of complexity there, but you know, it's a complicated algorithm.
Right. Another PQRS. I'm actually not sure if we covered this on webinar number 3, but if we are exempt from PQRS reporting or federally qualified health center, will we have access to a QRUR? If we're exempt from PQRS.
Yeah, you should. Now, based on the mistake I just made previously, I'm looking right back to state. There is no explicit mention. Yeah, exactly. I want that there's no mention of FQHCs receiving one. It's all driven by whether or not your TIN has received Part B payments. So if your FQHC has not received Part B payments, then you really should not be getting a QRUR if you're funded purely out of HRSA, for example. On the other hand, if you have providers and they are billing Medicare, then really you should be getting a QRUR because it's even for solo practitioners that should be getting it for the 2014 year. Now, one thing I really want to emphasize, because this has been something that has been big for this year, for the 2015 performance year. I think one of the key changes for this year versus 2014 is that any Medicare Shared Savings Program, ACO, now is subject to the value-based modifier quality tiering. Okay, and that's very important because in 2014, that was not the case, where all the MSSP ACOs had a free pass and were exempt from VBM entirely. 2015 is the first year in which all MSSP ACOs are subject to VBM quality tiering, and that does include the possibility of getting a negative adjustment because of low performance on your submitted G-Pro measures relative to peers nationally. And these peers are all TINs, not just ACO TINs that you'd be rated against. Okay, so again, if you have more information, if you want more information about that, just email me, tom@saignite.com. But it has been a gap in knowledge, I think, of folks in the shared savings program not necessarily being aware of what's happening with value-based modifier, and that free pass is expired. And this is the first year in which it's expired.
Wow. Couple more questions, and then we've got to wrap this up. Will electronic ECQM reporting replace the PQS reporting in an effort to harmonize the quality ecosystem? Like, your opinion on that?
That's an excellent question. First off, just to clarify, technically ECQM is just a form of calculating and submitting PQRS measures. You know, it just goes right alongside a registry method as well as web interface, so on and so forth. Now, where ECQMs are different is that they came out of meaningful use originally.
Right.
And for several years now, there has been the opportunity for meaningful use organizations to submit their CQMs electronically and thereby also get credit for the PQRS standalone program, as well as for meeting the minimum reporting requirement for VBM. But I think the real core of the question there is whether or not CQMs will become a replacement for other forms of PQRS reporting. And I think that's an interesting question. I don't know the answer to it. What I do know is that EHR Direct, which is the method by which you submit CQMs, is growing very rapidly in the market with all the major vendors now supporting it, and many of them even supporting it at no additional cost. So if you look at that compared to other reporting methods, That's an interesting thing to think about. On the other hand, CQMs also have their limitations. You have a smaller set of measures. It's a little bit more of it. It's a little bit more reliant on providers to enter data properly, because CQMs are calculated really algorithmically versus a registry, for example. The people who data extract for a registry are able to look in different parts of the patient record. Okay, not just where you think the data should go, but even in the free text notes. And that's the same with the web interface method, is you have that potential advantage, although it can also be very cumbersome and labor intensive to do that. So I think it's an interesting question. We do see a lot of movement towards CQMs, but I think overall there's a big movement away from claims-based PQRS reporting. And that's probably the biggest trend that's going to raise the water level for all of the other reporting methods.
Right, right. Well, on that note, we have actually run out of time. I want to thank everybody today for joining the broadcast. Tom, thank you. And we will obviously be back next month with another ABCs of MIPs. If you didn't get to your question, please email Tom at tom@saignite.com. I know that he looks forward to engaging in the audience. Check out that LinkedIn group, Merit-Based Incentive Payments. And let me see if I can go back there.
Oh, there it was.
Was it right there?
On the second, yeah, it's like the second major bullet on other resources.
There we go. LinkedIn group, Merit-Based Incentive Payment System. If you go to LinkedIn and search that, that should come up. Definitely check out SAIgnite's VBM Frequently Asked Questions on their website. They've got a number of FAQs, a growing number of FAQs related to PQRS and VBM and MIPS in general. And then, of course, you can also download their MIPS financial calculator, a very handy, dandy tool. Tom, we'll see you again back in October.
Sounds good. Thanks, Carol, and everyone for attending.
Have a great weekend.
You too. Bye.